Hello, hello, everyone. So nice to see you all today. It is Juneteenth, and we're happy to have you with us. My name is Allison Elsner, and I'm the CEO of the San Bernardino County Medical Society. I am joined by my colleagues, Janice Solorio, our COO, and Debbie Long is on the line with us, our Community Outreach Director. So we are really happy to continue this series. This is the fifth in our clinical education webinar series, sponsored by IEHP and produced in partnership between SBCMS and Riverside County RCMA, Riverside County Medical Association. So we do want to thank IEHP for being so supportive and helping us develop this curriculum, along with our program director for this, our SBCMS president, Dr. Will G. So as you know, the purpose of these sessions, of which there are 12 throughout the year, one each month, the purpose is to really provide tools for primary care providers to understand how to better treat patients in a holistic way. And that includes when to conduct referrals to specialists and how to improve your own workflows so that your own patient outcomes benefit from this and ultimately better patient care in the long run. So today we have a really wonderful speaker. I think most of you on the line know him, Dr. Eric Hansen, family practice, solo practice in Hesperia, California. And I am going to introduce Dr. Hansen. Now, I will tell you, he has a very lengthy introduction, so I'm only going to be able to touch on a small portion of his many accomplishments here. Dr. Eric Hansen currently serves as Vice Chair for the Board of Trustees for the California Medical Association. He has his own family medicine practice in Hesperia, California, established in 2002. He's a board-certified primary care physician and graduated from Western University of Health Sciences College of Osteopathic Medicine of the Pacific in 1999. He is a 2015 recipient of the CMA's statewide Dev A Ganadev MD membership award. Dr. Hansen also serves as a clinical rotation faculty member for instruction of medical students at Western University of Allied Health, and he serves as clinical faculty for UCR Riverside School of Medicine. In addition to being the past president for SBCMS, Dr. Hansen served for many years as trustee for the CMA Solo and Small Group Practice Forum after representing the forum for 5 years as chair and 12 years as a delegate. Dr. Hansen also represents CMA as a longtime member, CMA's Health Advisory TAC, CMA's Governance TAC, Chair, CMA Rules Committee for the House of Delegates, Executive Committee, CalPAC, and Chair, CMA Rules Committee for several years. I think I just said that twice. He also served as Vice Chair for our Legislative Commission for SBCMS. Dr. Hansen lives in Oak Hills with his wife, Suzanne, and his daughter, Amelia. And we're super honored to have you here, Dr. Hansen. So please take it away.
Well, thank you, Allison. You reading that list, no wonder I'm so tired today.
No kidding.
First off, thank you really to the SBCMS team, the San Bernardino County Medical Society, and all the work you guys do, and also IEHP for actually sponsoring these discussions. And I've listened to a few of them, and they're actually really well done. And I appreciate you guys inviting me to be part of it. So we've got some slides prepared, and you guys probably saw, just as far as the introduction was concerned, that we're talking about chronic diseases, and the talk is actually kind of tuned to physicians, but I know we may have some non-physicians on the talk today. So I'm going to make things as straightforward as possible so that everyone can get information from the information that I'm going to present. And if it means that it's just that you take stuff back to your primary care doctor as a non-physician to ask questions, or if you are that primary care physician, that maybe I'll give you some insights on some latest stuff that we're seeing that can help you with with workflow, with handling chronic disease patients as best as possible without getting bogged down. We have a lot of things to do as primary care doctors. And when we have patients that come in that have multiple clinical diseases, it's easy to get overwhelmed. So we're going to try and kind of streamline some of that process and, put out some criteria that is maybe newer for some folks that also will help on management. So I think Janice is going to handle my slides for me. So we've got our agenda here. So the burden on chronic disease is going to be really the first thing that we're going to get into. So we can probably go ahead and go into the next slide, but you can see briefly before you change. I'm sorry, I screwed you up there. If you can go back one, if you can just see that we're going to also be covering, though, as far as those chronic diseases, the big ones, which is diabetes, chronic kidney disease, cardiovascular disease, eye-related issues, and asthma. I'll even throw in a little bit, if we have some time, on another big chronic disease, which is post-COVID syndrome and actually COVID and how we're responding to that lately. So now you can go ahead and switch that slide. Thank you, Janice. All right. So understanding the current prevalence and trends. So we've got a lot of data that's available for us. And, as far as chronic diseases are concerned, it's kind of a ever evolving process. And so, using evidence-based screening guidelines is something that we can utilize to basically try to handle these chronic diseases better. And the whole goal is to really try to get it with this improved management before these disease processes cause more significant concerns, hospitalizations, and the like. So this is something that happens, primarily at the primary care physician level. And this is something that we need to do as good a job as we can so that we can prevent hospitalizations and worsening of chronic disease. So that's really the whole impetus for why this talk was put on in the first place, is to try and see what we can do to improve what we're doing already. Next slide, please. So we've got, I think, some data. So go ahead and go to the next slide. Yeah, so here we go. So as far as prevalence of chronic diseases, 6 in 10 adults in the US have a chronic disease of one sort or another. So it's a significant number of the country. 4 of 10 people have 2 or more of these chronic diseases. And as many of us primary care docs know, that when we see our diabetic patients, for instance, a lot of times they've got associated kidney disease for sure, heart disease potentially, probably hypertension. Asthma is kind of an outlier. That's maybe more autoimmune, inherited predispositions or acquired. But we for sure, once you have that diabetes diagnosis, we can expect that we're going to have a whole trailing number of disease processes after the fact. You can go ahead and go to the next slide. So these chronic diseases, they cause basically 7 of 10 of the deaths that annually occur in our country. So we've got, a significant number of prevalence of deaths. Primarily, I think the next slide kind of tells the breakdown on that, that diabetes is a big part of that. And so we have the significance of coronary artery disease playing a huge role in the numbers of deaths that we see in this country. And many of these things, and if not all, are significantly preventable. So we'll start off with diabetes. And so go ahead and go to the next slide. We're going to just talk a bit about that in particular. So at 11.6% of US adults, judging by 2023's data. Last year, probably we've got an increase because every year it seems we're increasing in the prevalence of diabetes in our population. So a significant number of folks, you're talking, in the millions, of course. And so this is something that is many times tied to multiple comorbidities of obesity, as well as hypertension and the like. So the screening guidelines, if you have someone that's basically over 35 with a BMI that's greater than 25 or greater than 23 in the Asian population, we definitely need to be screening for diabetes. And that's basically done not just with a fasting glucose, which many of us may do with just their normal CMP, their chemistry panel, but also including a hemoglobin A1C, the long, basically average blood sugar test that will look back over the past 3 to 4 months and tell us where your average sugar has been. So those A1Cs are important to do, and just even if it's annual screenings, but in some cases where people have multiple comorbidities, we may even bump that up to every 6 months doing that screening for diabetes. Lifestyle, diet, exercise, weight management, these are all things that we should incorporate initially. So if we end up having people that are even coming in the glucose intolerance range, or just even borderline hyperglycemia, where their A1C may be just slightly off, and we may want to get some intervention done to hopefully prevent them heading into the diabetic range at a later time, that's when we should be having those discussions about diet, exercise, weight management, and the like, and not waiting for these levels to become significantly out of control. And as far as those numbers are concerned, even an A1C at 5.7 to 8 is an indicator that we're starting to head into having average sugars up higher than they should be. And that's when I would say, that's when I know I speak to my patients about, making lifestyle adjustments. Go ahead and go to the next slide. So as far as medications are concerned, there's a lot of medications out there. And many times in primary care, we have to do what the payers are covering these days. And so that's a huge issue for us, especially in primary care when we're talking about, treatment, first-line treatment for diabetes. When we get someone that comes back with an A1C that's greater than 6.3, that meets that criteria for officially diabetes. And the question is, what do you do then? So I know as far as for me, I do not start medications right off the bat. I will try to aggressively work with the patient on doing exercise, dietary changes, and getting them involved with a nutritionist and having close follow-up to see if we can actually reverse this process without the utilization of medication. Basically, every medication we give has the potential for side effects. So we should always be trying to do the best we can with preventative measures, dietary, exercise, and the like. There's a lot of information out there now on the GLP-1 drugs, the Ozempics and the like, generally, utilized to a large degree for weight loss, but initially they were designed for the treatment of diabetes. Now, these drugs are kind of the newest in the line. There's GLP-2s that actually have been around for a while longer and have had significant studies coming back showing reduction in cardiovascular and renal impairment disease when those medications are used. But to start them as first line is difficult because many times the insurance companies will want us to do a step edit where you have started them on basic generics such as glipizide or metformin. And so there's a challenge there, as all of us know, with utilization of those drugs. Metformin, for instance, though, it's one that's readily used, but we need to use caution with it because it has a high propensity for causing worsening of kidney disease. So it's a complex situation where high sugars hurt the kidneys, but so can metformin. So I utilize lower doses of metformin if at all possible, at that meaning that like approximately 500 milligrams twice daily. Rarely, if I can avoid going to 1,000 milligrams twice daily, I'll do it if I have to, but try to avoid that. I would actually even add a second line medication or an adjunctive medicine before going up on that metformin if I had a choice. But metformin is pretty safe for at least a few years, especially in elderly population, because it doesn't result in the significant hypoglycemia episodes where the sugars drop significantly, like you can see with other medications. So it's still readily used, but the other drugs that have to be added on adjunctively, like the GLP-2s and the ones, are usually something that's done as a third line course of treatment. Though that may change as far as the trending of heading away from metformins, and also because of the utility of these other drugs with multiple comorbidity diseases in heart disease and the like. Like I had mentioned before about the A1Cs, monitoring every 3 to 6 months. If you have a confirmed diabetic patient, then definitely it'll depend on how well controlled they are. So if they've really done efforts and they're bringing their sugars into well control, you may be able to go to every 6 months on their A1Cs. With that first diagnosis, though, it's probably reasonable to do every 3 to 4 months on the A1C monitoring to make sure that you're following them closely, and then they may keep a journal or a log of their fasting sugars as well to help a little bit more. The A1C, for those that aren't familiar with it, is this long look at where the average sugars have been. It's actually a molecule on the hemoglobin of their red blood cells that gets affected by the sugar levels in the blood. And the lifespan of a red blood cell is approximately about 90 days, so about 3 months. And so this looks back back over the past roughly 3 to 4 months, telling you how the sugar levels have affected this molecule on the hemoglobin. So it's a really tricky test that was invented a long time ago and really has become a game changer on management of diabetes for years and years. But that's how that works. If people are wondering, and how can they even tell where my sugars have been? Because they try and really behave on their diet that week or two before their appointment, thinking they're going to get away with it. And then we see their A1Cs at 7 or 8, and we're like, well, I know that your average sugar has been pushing 300, and so because I can tell from that test. So that's how it works for anyone that didn't quite understand what that test is. As far as complications with diabetes, they are multiple, and it affects pretty much every system of the body. But the big ones that can be significant would be the eyes. So the risk for retinopathy or damage to the retina is significant when the sugars are elevated at high levels. And even long-term exposure to moderate elevation of the blood sugar can cause retinopathy or damage to the retina. So it's important that those patients, once that diagnosis of diabetes is made, that they absolutely get in at least annually to get even the basic eye exam done by optometry. They don't have to have ophthalmology do those exams, as anyone that's gone to their optometrist lately sees that there's about 5 machines that they put you in front of, checking eye pressures, retinal scans, and all these things that weren't always done by optometry, but now they have the capability to do very thorough eye exams even on diabetics. So just basically try and get your patients out there to optometry minimum once yearly, and then if any complications occur, obviously at that point escalate to ophthalmology if needed. Blood pressure control, you can end up having vascular and endovascular changes because of the high sugar as well, leading to potentially long-term effects that can result in elevated blood pressures. Foot care, because of the lack of circulation potentially that can occur with that vascular disease, you may get microvascular changes at the capillary level with those diabetics, and they end up getting tissue damage. And that's why it's so important to do those foot exams with those diabetics when they come in, because they can form ulcers and it damages the nerves as well, and they won't even feel pain or know that that's going on. So it's important to check that. Lipid screenings, definitely with the elevated blood sugars, you'll get associated hypertriglyceridemia. So those lipids will definitely go up. And so important to do that fasting lipid profile. We've got a little more information now lately coming out that there's potentially more role in triglycerides as far as the potential for increasing risk for cardiovascular events. We used to believe it was only just really the LDL, the low density lipoprotein, or the bad cholesterol that was the predictor. But now we can see that triglycerides are playing a bigger role. And you can look into that. There's a whole subject on that. But next slide. All right, so moving on to kidney disease, another one of the big ones. And so next slide, thank you. So the prevalence, whoops, one back, there you go. Prevalence, about 15% of US adults have chronic kidney disease, but probably only 10% are aware of it. That is because it's one of those things where you don't really necessarily get symptoms. You may have people that'll get maybe some flank pain when they have severe damage to the kidneys that's medication induced or infection or the like, but most of the time the decrease in kidney function, absolutely asymptomatic. And these people have to have monitoring done generally, especially with diabetes, at least twice yearly. As far as the standards on chronic kidney disease, that's kind of an ever-evolving story. As many of you may notice that the laboratory studies, when they come back, their standard is that normal is GFR, or glomerular filtration rate, less than 60. But generally, chronic kidney disease is anything less than 90 on a GFR. So you'll have stage 1 at 90 to 80 and stage 2 at 80 to 70. And then you get down to 60 and you're like, just a little either plus or minus of stage 2 kidney disease, even though the lab says that you're normal. So you have to be aware of the latest standards on kidney disease, that there are some changes, and those indicators can be age related, but they can also be related to diabetes. So you have to pay pretty close attention to where that kidney function is and document it so that you're made aware to kind of continue to monitor that. Screening, I kind of already talked about that, but it can be related to elevation of blood pressure as well, because of the renin-angiotensin process that occurs in the kidneys. You can have an effect with kidney disease that can result in changes in blood pressure management. So you want to be sure that you're checking those vital signs, which we all do every time that patient comes in. The age-related effects on the kidneys too, definitely something over 60. Even if someone is at more high risk though with diabetes, it's going to be much earlier than 60 60 that you're going to need to be monitoring renal function. So anytime you're seeing any blood sugar issues, you basically just need to do those chemistry panels, and that's the GFR and then the creatinine levels as well. The creatinine will trail a bit further past GFR. So GFR is a good early predictor, but it also fluctuates with dehydration as well. So you have to put everything into perspective and just advise on hydration prior to getting those laboratory studies done. So they drink their water, even though they think fasting means no water. So that's what I would say about that. But next slide. So management, and think we are still on renal disease. So blood pressure, you're going to want to try to maintain those blood pressures at least below the 130s, even 135, depending on age. So if they're getting up into the over 75-year-old bracket, we are kind of accepting a little higher blood pressures because those arteries have become a little bit more rigid. Maybe there's histories of stroke and you don't really, or heart issues with blood pressure, and maybe arrhythmia. And so you have to be a little bit careful with blood pressure not to go too low, or you may induce syncopal episodes or the like. So a good target, those in the 130s, 135 range. ACE inhibitors and ARBs, angiotensin receptor blockers, definitely medications that are essential once you have that diagnosis of renal disease, or especially with diabetes, to hopefully prevent renal disease. And then also monitoring for proteinuria, so microalbumin testing for sure with the diabetics. But even if you want to monitor the renal function a little bit closer, also another indicator that can tell you overall renal function, when you may look like things are normal when you do a basic metabolic panel and the creatinine looks all right, but if you haven't done a GFR, you may see that those numbers vary. And so there's also other medications out there that are focusing just on improving renal function. Without saying brand names, there's one that is just in its class all alone, and you'll be able to look that up. But that would be for people that have decreased renal function without any signs of reasons why. So you don't have diabetes to go by, but that may be age related, but it might even be early renal function impairment, and they're saying they're drinking their water and they're not on any meds that could be hurting the kidneys. This may be idiopathic, and so there are some meds that can kind of help with that as well if needed. Referral triggers, like when do you send somebody to the nephrologist? And so just because someone has a GFR that's going down, it doesn't mean you necessarily get them to nephrology. So generally speaking, the criteria would be once that creatinine hits 2.0 and above. So you get to that, and that equates to about or approximately a GFR of less than 30. And or if they are having multiple other complications, such as their blood pressure is resistant to treatment, that implies that potentially we have a renal manifestation of hypertension. So that may be another reason for nephrology to pay attention. Next slide. Next slide. There we go. Okay, cardiovascular disease. So leading cause of death in the US, as I said before. So 1 in 5 deaths are from heart disease. Crazy. And this could be, in a lot of cases, prevented. So we've seen a real uptake too in the last 5 years with the situation with COVID, the pandemic. We know that this virus increases risk for clotting, and there have been a significant uptick in vascular events, not just heart attacks, but strokes and the like, since the advent of this virus. So something to absolutely consider. But screenings, we do, the lipid panels, meaning the fasting lipid profile. So you're doing LDL, HDL, maybe VLDL, and also triglycerides. These numbers all play a role in stratifying the risk of cardiovascular disease. And so the cohort equation, pooled cohort equation, this is something that basically you can access online. There's a calculator that's available. You just type in the PCE risk assessment tool. And this basically is a tool that calculates or stratifies the 10-year risk of coronary artery disease and stroke by taking into account age, sex, race, total cholesterol, HDL, blood pressure, hypertension history and treatment status, diabetes, and tobacco use. So all these factors get put into this risk assessment tool, and it can give you a predictor for your patients to see how much risk are they at for cardiovascular risk. And so it's kind of an interesting tool to put in for those patients that you may not quite have a straight story on their risk, on how you want to work them up, how soon would you maybe doing more aggressive evaluation of their cardiac health. And so it's something you can check into. These slides will be available and also a transcription. So if you need to get that information later, you'll have access to it. Next slide. The next part of this is got to do with lifestyle changes. So we have DASH diet, which is a dietary approaches to stopping hypertension. So it's kind of a clever thing that, was put together to more or less talk about low fat, low sodium diet, and also smoking cessation, big one, cardiovascular risk and smoking absolutely tied together significantly. So something definitely to speak to your patients about. The medication approach, statin drugs, we have a large push by the health plans to have our patients on statin drugs. It's a little controversial because you have a fair amount of folks that have actually statin intolerances and are not able to tolerate statin drugs because of myalgias or maybe potentially liver impairment, or they have other diseases that involve the liver that precludes you from being able to use a statin. So in those cases, you do whatever you can with diet, exercise changes, as they are entirely tied to these improvements in cholesterol levels and lipid levels. There are also some supplements out there that do work, and I will absolutely utilize many supplements, such as omega-3 for the triglycerides, or even red yeast rice. It's been around for quite a long time, and it basically mimics a very low dose of statin, probably equivalent of about 2 milligrams. And that in some people can even drop LDLs. I've seen up to over 60 points. And so really significant, but on average, probably 15 to 30 point reduction, just using the over-the-counter lipid lowering agents that are available to us. So I always will try to do what I can with doing dietary, exercise, and supplementation, and then move to those statin drugs when we basically have no choice, or we see that there's a genetic predisposition and we're probably not going to get very far without those statins. But even at that, I will usually start low and go slow, which is what we were all taught in medical school. But if you look at the criteria for people with known heart disease, there's a basic minimum of 20 milligrams, generally up to 40 or even higher, to be within compliance on the standards that were put out by previous studies from the cardiovascular studies that were done on statin drug use. So I encourage you to look those up. I still try to be conservative with statin use and really monitor the numbers and not go by the dose, because it seems to really affect a lot of people differently depending on dose, and side effect profile definitely dose related. The management of diabetes, I kind of already mentioned, that is essential with cardiovascular risk reduction as well. So those two kind of go without saying. Next slide. And now we're moving on to chronic eye disease. So glaucoma, macular degeneration, two big ones that, very preventable, especially with glaucoma, as far as prevention of blindness. And not necessarily that you can prevent glaucoma and macular degeneration entirely, but if you catch them early, you can actually improve the odds and the outcomes on those patients by making sure that they have that management early on. So I recommend anyone, even over 50, to go ahead and do an annual eye exam with their optometrist, and they will screen for glaucoma, and they're doing the retinal scans and seeing if there's any evidence of macular degeneration, and then moving on to ophthalmology at that point for specialty care if needed after the fact. So as far as when to refer on that one, make sure they're getting their annual screens. And with any of these other chronic diseases, such as even the heart disease, you may end up with having vascular disease that's showing up on the retina, and you have retinal vasculopathy, and that can be found on exam as well. So it's just multiple reasons why those eye exams are important. They're the window into our body in many cases. The dilated retinal exams, the screenings that are being done now with the machines that actually are able to get really great images on our retinas, the old days, you had to always do that dilated exam. And so these, current criteria may be, as long as you get that retinal scan and you get a good image off that machine, you may not have to have the dilation necessarily done, but you do need to get the retinal exam. Intraocular pressures, like I had said, I'm saying like at 50, but they're even saying on the criteria that even less than 40, that you may need to start, monitoring for glaucoma. So not a bad idea. Earlier is always better. Next slide. All righty. And so reinforcing screening adherence. So this gets into, basically our communication with our patients. And so that's the main thing I would say with primary care that is really our task. And it's to make sure that our patients understand the significance of the disease processes that they have, and that we need to have them take part in their health, because we can tell them everything that they need to do. We can preach to them all we want, but if they don't take the meds, or if they don't get the screenings and they don't go to these appointments, then nothing will be avoided, nothing will be helped, and they won't have prevention that they could have access to. So it's really important that we get that across. And when I talk to my diabetic patients and tell them you should get your eye exam, they'll say, oh yeah, okay. And I'll say it's really important because the sugar levels can affect your retina and you can end up with blindness. And you go through all the steps and take that extra few minutes to explain why it's important. Then next thing you know, they did go get that exam because they didn't realize that it was actually all tied together with their other disease processes. Next slide. So asthma. So this one's a little bit of an outlier, but one important thing too for the primary care doctors that are involved with HMO plans and medical groups, for instance, that may be familiar with risk adjustment. There was a lot of changes with version 28 on the risk adjustment scoring codes that are allowed with our billing and the like. And so I'd be remiss to not mention that asthma actually now risk adjusts when it did not. Multiple other diagnoses no longer risk adjust. And so for the non-physicians, it means it's stratifying the severity of illness, basically. And so in this case, it's important that when we see our patients and they have an asthma history, that we now take that extra minute to classify their asthma and not just document asthma and that it's stable. We want to put asthma that's intermittent mild, or intermittent moderate, or intermittent severe, or persistent mild, moderate, severe. So there's all these different classifications that we need to be very specific on, and because they do determine what our treatment course will be. And so, but it's really important for you to go ahead and document that, I think more importantly this year than any years even in the past, because it may make a difference to your risk adjustment scoring for those that know what that is. The next thing, as far as diagnosis, spirometry testing, gold standard. You can see if you have restrictive airway disease. A lot of times history will tell you a lot. It doesn't always have to be that it's wheezing or coughing. If people do have that, though, having a symptom diary is important, because if you see that someone, you gave them, say, albuterol because they've got an asthma history and they generally are stable, but then, at least because they tell you they are, and then you have them come in next time and they actually, have their little diary of how often did they use their inhaler, and you see that they're using it 5 times a week, obviously we have a problem, because if it's over 3 times a week, that's persistent and it's unstable, and it's going to need to be treated with more stabilizing agents such as inhaled steroids and the like. So very important that we get more detail on asthma. Next slide. So, and I don't know if I said there was 25 million people in the US. I think I skipped that top part. But anyway, so stepwise approach. So there's some standards on how you go through the stepwise treatment approach for asthma. And you can look it up as the GINA criteria from 2023. But inhaled corticosteroids for those patients that are persistent, moderate to severe, or intermittent moderate to severe. The inhaled steroids are essential for managing those patients, and not just using the betas, the albuterols and the ProAirs and such. So that's something that definitely needs to be discussed when you have those patients coming in. Addressing triggers, allergies are a big one. So you'll see a major uptick in asthma, uncontrolled asthma, I should say, during the typical allergy seasons, such as the spring and sometimes in the fall. Smokers may be making their asthma much worse, so another discussion to have. And then environmental or industrial exposures and other triggers that can be an issue. Next slide. So patient education, written asthma action plans. So this is going to be, I mean, really trying to have your patients buy in with making sure that they keep that diary really is the best way to do it, because then you can get a good idea if these actually, these patients are actually unstable or not. Because many times people will have an asthma history, but it was childhood asthma and they haven't had an issue since they had a cold 3 years ago when they had some wheezing. So, that's going to be a whole lot different than somebody that's using an inhaler multiple times a day or even, several times a week. So I think next slide, you can go ahead and move on. So integrating management in practice. So next slide on that. So, basically, I would be remiss not to make sure that we cover the involvement of our staff and also outside sources. So I had already mentioned about dietitians with diabetes, essential to have them available unless you do a lot of diabetic teaching or you have a dietitian in your own office, which many of us don't have. Using pharmacists is actually helpful as well, because you can get the fill history on patients, especially ones that are supposed to be taking medications to prevent, say, asthma exacerbations, or if they're compliant with their diabetes medications or their hypertension medications. So chronic disease and feedback from the pharmacies actually pretty essential. And so you can get that information even right from your EHRs in some cases, but otherwise you may print up a pharmacy report to see if they've been filling their meds or not. Nurses implies really more kind of like your entire staff. And so it's going to be MAs, and you may employ nurses, but they are essential too with, compliance, with explaining why we're ordering labs we're doing, because I know we get busy and we'll just say, I want to get all these labs ordered for next time. And then the staff can then kind of reinforce with that as well. It's important you get your labs done and do it a couple weeks before your appointment, so we get, information that's relevant to your visit at the next time. These little things can improve compliance, which is really essential for managing these chronic diseases. EHRs, I'd already mentioned that sometimes we can see these medication reports in our EHRs, but also we have, many times built-in alerts that can pop up for screenings, not just even for their A1Cs or their eye exams or colonoscopies, but other laboratory studies with chronic kidney disease that may be essential. Mammograms, you name it, all those things. So it's essential if you have those built-in components in your EHR that you utilize them, because many times we'll just get into the business of using our EHR just to document the visit. And it can do so much more these days. And so take advantage of that is what I would say on that. Next slide. Self-management, support, registries, care coordination. So this is all using these outside teams and other types of activities or online services to help those chronic patients kind of keep track of their disease processes. So there's a lot of resources out there for them. I many times will print out diabetic diet information for my patients, and basically on everyone I will, but I'll even give it to them again later when I see that they're not really compliant, to just reinforce that. And so there's a lot of things that we can do, and then also direct them in the right direction. Social determinants of health. So this is basically, talking about those other things that are going to affect compliance with doing their blood work or taking their meds. And that may be that they can't even afford to feed themselves, let alone pay for their meds, or they can't afford gas for their car to get to their appointments. Or they have no home right now. And so these kinds of things are important that we ask initially when we have our patients coming into the office, and then also reassessing periodically to see if there's been a status change for that patient that's going to affect how well we're going to be able to manage their disease and how well they'll be able to do their own management. So it's just worth saying that we should also be paying attention to that, especially on chronic disease. Next slide. I think we're getting to the end. So I promised about some COVID stuff. It wasn't built into this talk, but I would be remiss if we're talking about chronic disease without bringing up the big elephant in the room for the past 5.5 years, which is the COVID virus. And so many times I'm surprised, because I'll have patients come in and they will say, when I'm talking to them about the illness they had that I treated, last month, and asking them if they're better, and that, judging by my assessment that even if they tested negative with their nasal swab for COVID, that it actually was COVID, because I have been testing their COVID antibody titers whenever they do their blood work as well, to monitor their immune status related to COVID. So I have basically seen from that data, since this test has been available for about 3.75 years, that we've been well into herd immunity for a good 3 years now, with the majority of the population coming back with very elevated, if not maxed out, COVID antibody titers, measuring the SARS-CoV-2 IgG antibody level. So you don't want that it's qualitative. You don't want positive or negative. You want actually quantitative level. And it'll tell you in more people than not that they have at least moderate to significant COVID antibody titers, and that they still end up getting re-exposure after re-exposure after re-exposure. And many of the times they will get more mild to moderate symptoms and not call the physician that they had the flu, because it really just seemed like allergies to them, because their antibodies have been maintained at such high levels that they're able to fight off the viral exposure for the most part, but it'll result in more mild symptoms. But that said, and what ties into the chronic disease situation is that any exposure to the virus can lead to an increased risk for long COVID symptoms, because you may get no respiratory symptoms, but end up with brain fog, end up with severe fatigue, or inflammatory arthropathies, joint pains that go on for months post-exposure, and people won't put all that together that they were actually exposed. So doing the monitoring of COVID antibody titers, I think it's essential, and it probably needs to be a whole nother talk, because unfortunately the FDA has not gotten on board with this. They haven't really even acknowledged the monitoring of antibody titers, but it's essential. In my practice, it's played a huge role for being able to give informed consent to my patients, and also be able to accurately treat my patients, because many times you'll see from those titers what has changed from just several months before, where their titers were nothing and they seroconverted and maxed out on their SARS-CoV-2 IgGs. So check into it. Like I said, it's going to be a whole nother topic for discussion. I'm going to be applying to the FDA actually to try to serve on their COVID response team to discuss just this issue. So I'm hoping to get appointed if that works out, but I'll try and do a follow-up for everyone on that, Allison, if I can get some more information, because it's really still so prevalent. And so many people will say, oh, COVID's still going on, but it absolutely is. Almost a daily basis, we're dealing with one form or another of an issue related to COVID. So for those primary docs, it's a huge thing, and we need to be able to give them as much guidance on this issue as possible. And also, we have our new Nimbus version, NB.1.8.1 variant, which has now been isolated, the COVID variant that is the newest one within the last month, that has 6 major mutations to the spike protein genetic strand. So basically, it's going to look a lot different than the variants that we've seen just in the past few months, and probably will account for a significant surge in COVID cases over the next month to two, I anticipate. And so be on the lookout for that. But I think with that, I'm finishing a little ahead of schedule. And I think if we had time for questions, we can sure take some if there were any.
Well, that was really, as always, really informative, Dr. Hansen, and we would like you to come back with a follow-up. I think that would be really, really helpful, depending on what happens with you.
Yeah, I would love to, as soon as I can, get that coordinated with you guys then.
Okay, let's definitely do that. That'd be great. I don't see any questions in the chat. Who has a question for Dr. Hansen here? We've got the expert on the line.
Yeah, it's kind of tough, because for the primary care docs on this call, it's like pretty much everything I was saying, they're like, yeah, I'm doing that. I'm doing that. I'm doing so it's probably not going to be a big revelation, but it's always good to hear, the kind of reminders on things, I think. And so I'm not surprised if there isn't just a ton of questions, unless there was some COVID stuff, because I suspect that might be something, that we're not all really, discussing freely. And so it's important to have those conversations.
So I have a question, Dr. Hansen, and my family history with my mom and the kidney disease and all that. What is an alternative to metformin if you feel someone, before you say short of advancing to a more drastic step like a GLP-1 or something.
Right. So, I mean, as far as medications are concerned, I mean, any medication has risk, and so as far as insurance coverage, that plays a role many times as far as what do you use first line on diabetes. So many times it'll be glipizide, which is another medication, but there's risk with glipizide. It can cause hypoglycemic episodes where people's blood sugar drops precipitously. So you have to take it only when you've eaten. And the older you are, the more sensitive you may be to it. Metformin's a little safer because it doesn't result generally in hypoglycemic episodes. So people that are not well versed in their diabetes and being compliant, it's a little safer because they're probably not going to have a problem where they drop their sugar down to 30 or something and get in trouble. So that's why metformin is still around. But those are the two main generic medications that are used generally as first line in diabetes. But I have a feeling that here, not too far in the near future, we're going to see some shift in that because we have such better medications now, but it's just boiled down to that they're expensive because they're brand name. And so I suspect as those things come off patent, usually it's about 11 years for these medications that come off patent and become generic, that there's a potential, especially on the GLP-2s, that we're going to be able to potentially use those first line more easily because they do benefit so many other things on renal function and heart function and the like, that many times, I mean, I won't keep people on those first line drugs for very long before I'll just switch them to the GLP-2s because they've got all of these other diseases going on and they really need the other med. And so, but you have to kind of run through the mill to get things covered sometimes on medications.
Wow. Okay. I don't see any others. So I have another question. Is kidney disease, once it gets to a certain point, if somebody did everything right and they were on like short of dialysis, is it reversible or does it get to a point of no return?
Yeah, so I mean, even in people that end up in stage 5 renal disease and they end up on dialysis, there are some cases where people can actually turn it around and they go off dialysis. But most of the time, when you get to that far gone, a lot of
Right.
times those folks they end up needing dialysis forever. But you can have acute injury to the kidneys that you're in the hospital for a systemic infection and you go into acute renal failure and you need dialysis and then you do it for a month or two and then all of a sudden your kidneys start coming around and they recover and then you don't need dialysis anymore. So it's really, it's got to determine if it's a chronic disease that led to that or if it was an acute episode. So it's not an easy answer to that question. But the prevention early on, you can see people that end up in stage 3 kidney disease initially because they came in and they weren't diagnosed with diabetes because no one had ever checked or they hadn't been to the doctor in 3 years. And you look at all this and find out that they're uncontrolled diabetic, stage 3 kidney disease, hypertension. You get them going on the right treatment. They do better with their diet. They bring the sugar down. They watch the salt and they make changes. And all of a sudden, all these things correct and they're no longer diabetic. Well, I mean, kind of once you are, you always are, but they're diet controlled diabetic. And then the renal function returned to normal or almost normal, and that their blood pressure dropped. And so these things can reverse. It's just, it doesn't have to be that once that damage is done, that it has to be there forever. So the earlier we intervene, though, the better chances you got that you're going to bring those folks back around.
Wow. Amazing. Okay, wait, here's a question from Dr. O. Thanks so much for your informative session. Do you have any preference among metformins, slow release or extended release in practice? Should we try with the ordinary one first?
Yeah, I would say the immediate release a little bit better and as low a dose as you can get away with. And then so you can even do 250 milligram. And I think that, generally it's a good adjunctive therapy, to your diet and exercise efforts and all the rest. And as a first line, still not bad to do, but just have a goal that within, probably 2-3 years, you're going to try to for sure get them off that metformin. And then if you start seeing renal impairment, the first thing you want to do is get rid of the metformin. And then be on the lookout, though, for the abdominal side effects, because many people, I had a patient this morning, she was new, just 3 months ago, she came in for a new patient visit. She had been to every doctor under the sun for her abdominal problems, irritable bowel syndrome, inflammatory bowel disease they had diagnosed her with, even though she had a normal colonoscopy. So I'm not sure how that one happened, but they didn't have anything else they could do with her. They were giving her multiple medications for abdominal symptoms of diarrhea, abdominal cramping, bloating. And I looked at her med list and I said, you need to get rid of the metformin and let's see how you do. She got rid of it. Immediately, all her symptoms resolved. And I got her off of 3 medications as a result because she was taking dicyclamine. She was taking, I mean, the list went on of all these, medications for the symptoms of her abdominal cramping, bloating, and diarrhea. So it was
Oh
just,
my God.
she was so grateful because it had been 5 years that she had been put on her metformin and had those side effects. And the first thing you should have thought of the minute you start on the metformin was that she's going to get abdominal side effects. So always think of that, So that's where many times a low dose of glipizide, it's at least going to get paid for by the insurance. It's pretty darn effective. It lowers the sugar pretty well. There's just that hypoglycemia risk. There's a little potential that with long-term use of glipizide, though, you're going to burn out those beta cells in the pancreas a little quicker and maybe potentially increase someone's risk for needing insulin way later down the line. But that's a drawback. So you always want to just try and do everything you can with encouraging the diet and the exercise part of it because it's essential because the majority of those diabetics it's all diet and exercise related. There may be some family history of predisposition, but it's not that they're type 1.
All right, go ahead. You were muted. Yeah.
And yeah, so I know we're probably cutting it right in there. So I don't know if anyone had any other questions, but again, I really appreciate you guys giving me the opportunity to at least share some information. And I really think that, like webinar number 4 on COVID probably isn't a bad idea for the near future here, just to come
Yes.
together on what have I been doing, what have others been doing, the whole long COVID picture, how are we treating it, all those things. It's just so much that you really just can't get information on out there. I mean, I live and breathe this stuff, and it's really hard for me to even get updated info. And so, anyway,
Amazing. That's amazing. Well, and when you're say webinar number 4, because what you're talking about is you did that wonderful 3-session series for us before on COVID. I mean, you were like at the time the only person really able to speak about it, and really update us. And so I think that would be fantastic. We will schedule that. So everybody online, be sure you stay, look to see when we're going to get that scheduled.
well, thank you so much, guys. And I know there's some stuff in the chat. I don't know if there was any questions in there. Looks like
I haven't seen any. It's mostly just some reminders and comments. And I think we covered the Dr. Noth. Thank you, said that was great. Thank you.
Gotcha.
And Dr. O. So everything else we've covered. And Dr. Hansen, that was fantastic. As always, you made it really digestible, no pun intended, and easy to understand. So thank you so much.
You're welcome. Thanks so much again. Okay, you guys.
All right, thank you. And thank you everyone for joining. We will have the slides and the recording that we will send out to you. And for anybody who wants CME, there's our QR code and we will email that to you as well. All right, everyone, have a lovely afternoon. Thank you again so much. Bye-bye. You did it. Yay! That was really, really